My name is Mark Banaka. I'm a cardiologist and vascular medicine doctor at Brigham and Women's Hospital and Harvard Medical School, and I'm the medical director of the Aortic Center at Brigham and Women's Hospital. I'll be talking about thoracic aortic disease. I have no disclosures for this talk. The diagnosis of acute aortic syndromes is often difficult and delayed, and symptoms are often attributed to other causes. And I'll just say that in general, as we go to the second bullet here, this is an issue with thoracic aortic disease that in the stable phase are often asymptomatic, and sometimes the symptoms of unstable aortic disease are variable, and these are highly morbid conditions, so you have to have them in the back of your mind. You have to have a high degree of suspicion. Fortunately, when we do detect stable disease, such as an aneurysm, in the asymptomatic phase, treatments are possible, and treatment before there are complications such as rupture or dissection do improve outcomes. And it's also important to note that patients who have aortic disease generally are older patients with risk factors, not always, but generally are. It does travel with things like atherosclerosis, and so that when we treat these patients, we think about their global cardiovascular risk and how to reduce their risk, both from their aneurysm, but as well from their atherosclerosis and risk factors. So I'm going to talk a little bit about atherosclerosis, spend a bit of time on thoracic aneurysms. We'll talk about dissections, and then we'll talk about vasculitis and some inflammatory diseases. It's critical to note that for thoracic aortic disease, imaging is really key to establishing the diagnosis. Of course, we can't image everybody. There are risks such as radiation exposure and risks related to contrast, and imaging is expensive, and so we can't just image everyone, but we really need to determine who is at risk. So identify and treat stable patients who are at risk, screen where appropriate, and certainly consider acute aortic syndromes as a potential diagnosis in patients presenting acutely, even if symptoms are somewhat atypical, if there are other risk factors. And we'll talk about some of those ways of risk stratification. I will be referring to consensus guidelines. You can see the reference at the bottom of the slide here, and different classes of recommendations here outlined on the slide, also with varying levels of evidence. So let's think about thoracic aortic aneurysm. We'll talk about the epidemiology, testing, what should you do when you find it, in terms of treating the patient for their overall risk and also monitoring, and when should you consider referral for a procedure. In terms of the definitions or terminology, when we use the word aneurysm, we're talking about an at least 50% increase in the diameter compared to the expected normal diameter, and all three layers are present. Of course, that distinguishes it from a pseudoaneurysm. When we talk about a thoracoabdominal aneurysm, that's one that involves usually the descending thoracic aorta transitioning through the diaphragm into the abdominal aorta or visceral segment. An abdominal aortic aneurysm is one that is isolated to the abdominal aorta below the diaphragm. And so those are some general terms. And again, we'll be focusing on thoracic aortic disease here. When we talk about ectasia, we're talking about dilatation of the vessel that doesn't meet the criteria for an aneurysm. So it's big, but it's not big enough to call it an aneurysm. Now, as I noted, aneurysm, you refer to a normal segment. We do see patients who have diffuse arterial dilatation across several segments, and we refer to that as arteriomegaly. And then finally, there's pseudoaneurysm, and this is really a contained rupture of the vessel wall. In contrast to an aneurysm where you have all three layers, here you have disruption of the wall, and it's usually contained by periarterial connective tissue. If it's freely communicating with the intravascular space, it's a pulsating hematoma. Oftentimes, it's not. So aortic aneurysm, the primary complication is rupture, and this is associated with very high mortality. Fortunately, rupture is predictable, primarily by the size, but also by the rate of change. When we use medical therapy, we target it to reduce the overall cardiovascular risk, as well as treating factors such as blood pressure and heart rate to reduce the rate of expansion, And elective repair at the appropriate time reduces the risk of rupture. Although, as we know, all procedures have associated risks, so we have to determine for our patients what is the optimal time to intervene. So the epidemiology. In general, thoracic aortic aneurysm is caused by degenerative disease resulting in dilatation of the aorta. It's usually a disease of the media of the aorta, or cystic medial degeneration. The incidence is about 10 cases per 100,000 patient years. Risk factors are those really associated with age and atherosclerosis, like hypertension, smoking, and COPD. But there are younger patients who develop these in sort of bimodal presentation, and these younger populations are characterized by genetic syndromes and bicuspid aortic valve, which is the most common congenital valvular abnormality, as well as some inflammatory diseases like Takayasu, which we'll talk about. There is a 2-to-1 male to female prevalence. I will say that in some cohort studies, although men are described as having a predominance, women do get aneurysms, but they seem to be frame shifted in age, that the sort of takeoff in the incidence occurs later in life. The most common site of the thoracic aortic aneurysm is in the descending thoracic aorta. Generally, it occurs in men in their 70s or women in their 80s, and it's unlikely in people under 50 unless they have a genetic syndrome. In terms of prognosis, as the diameter increases, the growth rate tends to increase. However, there is variability for of course, each individual patient. The survival rates really depend on whether or not they're corrected, but if you look at uncorrected aneurysms as they expand, 5-year outcomes are poor, mostly due to rupture. Patients with a diameter less than 5 centimeters have 90% 3-year survival, compared with 60% for those with one over 5 centimeters. The rate of expansion is associated with hypertension and particularly smoking. And it is important to counsel patients that they really need complete smoking cessation, and that continuing to smoke is associated with faster expansion of their aneurysm. Now, when we talk about the guidelines for aneurysm in general care, we really tend to focus on absolute measurements, but it's worth noting that the normal, or quote unquote normal diameter, is related to a couple things. One, can be normalized to body surface area, so larger people may have normal aortas. In addition, the normal diameter is also related to age, and so you can see on this figure here that as we get older, the normal range in terms of the location does increase. And so when you're going through decision making with your patient, especially with regards to intervention, but even with regards to whether a patient has an aneurysm or not, it's important to look at age and to consider body surface area. So what are some of the underlying causes of thoracic aortic aneurysms? Well, the majority, again, are in older people with risk factors, and it's degeneration. Now, in younger patients, there are genetic syndromes associated with cystic medial necrosis. There's Marfan syndrome and EDS, type 4 EDS. There are infections like Salmonella, Staphylococcus, and Streptococcus, as well as tuberculosis and syphilis. Vasculitides have been described, so Takayasu, generally in younger patients, giant cell arteritis in patients, older patients over 50, Behçet's disease, and then some of the seronegative spondyloarthropathies. Bicuspid aortic valve is an inherited abnormality. There's aortic dissection and trauma, and so these are all of things to consider in terms of which populations are at risk and the underlying etiologies. There are several gene defects associated with familial aneurysm and dissection. Now, these are generally genetic syndromes that are associated primarily with aortic aneurysm and dissection, although they can have other associated clinical features, which you have here. So there's TGF-beta receptor mutations, 4% contribution to the familial thoracic aortic aneurysm and dissection. associated clinical features are tortuosity, aneurysm, and thin translucent skin. In terms of other ones, so there's MYH11, smooth muscle cell specific beta myosin heavy chain. These patients may have a history of PDA or patent ductus arteriosus, and they can dissect at smaller dimensions. ACTA2, you may see, again, PDA, bicuspid valve, livido reticularis, and there are people that have dissections at smaller dimensions. In terms of genetic syndromes, Marfan syndrome is clearly associated with aneurysm and dissection. Some of the common clinical features are shown here. It's generally a defect in fibrillin 1, and there are diagnostic tests against criteria and also genetic testing. Surgical repair, usually when the aorta reaches 5 centimeters, unless there's a family history of a poor outcome or dissection at smaller dimensions. LDS or Loeys-Dietz. This is a related abnormality. These are TGF-beta receptor mutations. They tend to have bifid uvulas, a high arch or cleft palate, arterial tortuosity, hypertelorism. They can get aneurysm and dissections of other arteries, including medium-sized arteries, and tend to have a more malignant phenotype depending on the specific mutation. Again, these can be made by criteria as well as DNA testing, and surgical repair is generally recommended at smaller dimensions as outlined on the slide. Ehlers-Danlos syndrome, the vascular form, is associated with dimensions. These are COL3A1 mutations. This should be distinguished from purely hypermobile EDS. These patients have thin translucent skin. They also generally have histories of easy bruising, potentially muscle tears or muscle ruptures. They are at heightened risk of gastrointestinal rupture. So for example, if you have a patient, you make this diagnosis, they shouldn't get a traditional colonoscopy. They can get rupture of the uterus. And there are testing, generally genetic tests that can be done. Surgical repair is complex in these patients because they have friable tissue, and you may choose to weigh the risks of intervention with those of risk of rupture, and they may have difficulty healing. And then finally, Turner syndrome. Those are patients with short stature, bicuspid aortic valves. They may have a coarced web neck, and they have a clear genetic defect, a 45X karyotype. You can do blood cells for analysis, and they have heightened risk of aortic dissection and aneurysm. In terms of the testing, if you have a patient with Marfan syndrome, you should get an echo at the time of diagnosis and 6 months thereafter to determine the rate of enlargement, annual imaging if it's been stable, and if the maximal growth is greater than 4.5 centimeters or there is a change, if it's acting in a dynamic fashion, more frequent imaging. Patients with Loeys-Dietz or a similar genetic syndrome should undergo complete aortic imaging at the initial diagnosis and 6 months thereafter to see if there's enlargement, and then you can space those out. Loeys-Dietz patients, in addition, should have imaging from the cerebrovascular circulation to the pelvis because they can develop problems, as I mentioned before, in other smaller arteries. Patients with Turner syndrome should undergo imaging of the heart and aorta, and if it's normal, it should be repeated every 5 to 10 years. If it's abnormal, then annual imaging should be done. Again, if it's dynamic, you might do it more frequently. Now, the next one is quite important, and I think this is frequently missed in practice, but a first-degree relative of a patient who had thoracic aneurysm or dissection should be screened. And so aortic imaging is recommended. So if you have a patient in your clinic with a thoracic aneurysm or a dissection, you should talk to them about their first-degree relatives and make sure that they are also screened for aortic disease. And then if a mutant gene is identified, and you can see a number of them listed here, then the first-degree relatives should undergo counseling and testing, and only those who carry the mutation should undergo aortic imaging. As I mentioned, first-degree relatives with aneurysm or dissection here as well for bicuspid aortic valve. And they should be looking both for the presence of aortic valve but also for asymptomatic thoracic aortic disease. And All patients with a bicuspid valve should look at both the root and the ascending thoracic aorta for evidence of aortic dilatation. So oftentimes a transthoracic echo is only going to show you a small part of the aorta, and imaging the ascending aorta is also important because they may have aneurysm that's not visualized just solely at the root. So how do thoracic aortic aneurysms present? Well, as I mentioned at the outset, one of the problems with this condition is that it's largely asymptomatic, and so that people can develop large aneurysms without knowing it and be at risk of dissection and rupture. There are some patients, as the aorta dilates or associated with a valvular abnormality, that develop aortic insufficiency or regurgitation and congestive heart failure, so that's something to consider with new presentation of heart failure. You may also get a mass or compression effect in the chest related to a large aneurysm, and that could be cough, dyspnea or wheezing, dysphagia, hoarseness, sometimes chest pain, or even evidence of venous congestion. Now, clearly, the most likely cause of something like hoarseness or dysphagia is not an aneurysm, but certainly if there are patients who have persistent symptoms in spite of traditional treatment or workup, it's worth considering, particularly if they have risk factors like longstanding hypertension. So in terms of what we do once we make the diagnosis, well, we want to do risk factor management and medical therapy in everyone with the primary goal of reducing overall cardiovascular risk. So we want to have strict control of hypertension, lipids, and other risk factors, absolute cessation of smoking. We do want to lower blood pressure, and now with newer blood pressure guidelines, actually we're thinking about lower targets than what's on this slide. And so we really want to optimize blood pressure. And I'll say that lower blood pressure generally is better. Beta blockers in patients with Marfan, so beta blockers, ACE inhibitors, or angiotensin receptor blockers to the lowest tolerable blood pressure, with a preference for angiotensin receptor blockers in Marfan disease. And then statins. Lifestyle counseling is recommended, as I mentioned before, complete smoking cessation. And then we do need to give some guidance about activity limitations. So we want to advise patients to avoid behaviors or things that result in Valsalva, including strenuous lifting, pushing, or straining. Generally, moderate cardiovascular activity is fine, but burst-type exercises, competitive athletics, and so on should not be recommended, or should be recommended against. So for patients with thoracic aortic atheroma and atheroembolic disease, we treat with a statin, and anticoagulation or antiplatelet therapy may be considered when there is a large atheroma to prevent a recurrent stroke. So when you made the diagnosis and you've initiated preventive therapy, then the next thing to do is to monitor, to do surveillance, and then to decide whether an intervention is needed, and that's largely based on size. And so these data from the guidelines show you that there's a clear hinge point at about 5.5 to 6 centimeters where the risk of a complication rise dramatically. And so this helps guide our threshold for intervention. But it is worth noting that some patients will dissect or rupture at smaller dimensions. And here you can see about 60% have a problem at a dimension of less than 5.5 centimeters. So other things to look at again are age, normalization for body surface area, is there an underlying connective tissue, or are they behaving in a way in terms of their changes in measurement that make you concerned about an unstable process? So are they dilating rapidly? So when do you repair? Well, for asymptomatic patients with a thoracic aneurysm, when the ascending aorta or the sinus diameter is greater than 5.5 centimeters, that is when we generally consider intervention. Patients with genetically mediated disorders like Marfan may undergo intervention at smaller dimensions, 4 to 5 centimeters. Now, beyond the absolute dimension is a rate of change. So number 3 here is there's a 0.5 centimeter per year growth rate. Even if the dimension is less than 5.5 centimeters, you would consider intervention. And if there's a patient who already needs a valve replacement for aortic stenosis, aortic insufficiency, and their ascending aorta root are greater than 4.5, you would fix it at the same time as fixing the valve. In terms of Class 2A recommendations, for patients with Marfan syndrome, other genetic diseases, or bicuspid valves, when the ratio of the maximal ascending aorta or aortic root divided by the patient's height in meter exceeds 10. If you have a Marfan patient who's a woman contemplating pregnancy, it's reasonable to prophylactically replace the root and ascending aorta once they get to above 4 centimeters. And in patients with LDS, Loeys-Dietz with a TGF-beta receptor mutation, when the aortic dimension reaches 4.2 centimeters or greater by TEE, or 4.4 to 4.6 by axial imaging with CT or MR. So just to summarize that, that's a lot of information. When do we intervene? 5.5 centimeters is what you should have in your mind, or expansion at a rate more than 5 millimeters, 0.5 centimeters per year. If they have a genetic syndrome, 4 to 5, and if they're contemplating pregnancy, if Marfan syndrome greater than 4, if you're doing aortic valve surgery anyways for a dimension greater than 4.5, and bicuspid valve has changed. It was previously 4.5 centimeters or smaller dimensions, and now it's 5.5 centimeters. This was a recent publication by a group of experts that felt that we could intervene at larger diameters. In terms of surveillance, here's a schema to guide you. If the aneurysm is 3.5 to 4.4 centimeters, you get annual CTs or MR. If they're 4.5 to 5.4 semi-annual, you can see the indications for operative repair there in the middle of the slide. If they don't meet those criteria, you continue surveillance. If they do have operative repair, then you look to see if they're a suitable operative candidate, and if not, you continue with risk factor modification. Again, here, if there's an indication for operative management, then perioperative assessment. Again, if no, then risk factor modification. If they are a suitable candidate, look for other coronary disease or valvular pathology that may impact the type of intervention that you do. Now, in patients with a genetic disorder, we do size-adjusted disease surveillance. Again, 3.5 to 4.4, you do annually, 4.5 to 5.4 semi-annual repair based on the guidelines on the slide, and then medical management. As I mentioned earlier, there has been an update to the guidelines in terms of bicuspid aortic valve. This was published in 2016. This has been out for a couple of years, but it recommends that for bicuspid valve, we can intervene at larger dimensions. So Class 1 here would be operative intervention to replace the ascending aorta as indicated in asymptomatic patients when they reach a dimension of 5.5 centimeters or greater. 2A is 5 centimeters or greater if there's an additional risk factor for dissection, so something like a family history or a high growth rate, and if they're low surgical risk. And then 2A, if you're going to fix the valve and they're above 4.5 centimeters, then you would fix it at the same time. In terms of the arch and descending aortic disease, here are several recommendations. So for chronic dissection, particularly in the context of a connective tissue disorder, but without significant comorbid disease, 5.5 centimeters with an open repair. If they have degenerative or traumatic aneurysms that are greater than 5.5 centimeters, saccular aneurysms, postoperative aneurysms, or then stent grafting should be strongly considered whenever feasible. Now, number 3, if endovascular stent graft options are limited and they have high surgical risk, then you may consider deferring elective surgery until the dimension is 6 centimeters, but and maybe less if it's a connective tissue disorder such as Marfan or Loeys-Dietz syndrome. So the difference here, of course, is that surgical repair is a more morbid approach, and if someone has high surgical risk, you may wait a little bit longer before sending them to surgery. And then for patients who have aneurysms with end organ ischemia or stenosis of the visceral arteries, an additional revascularization procedure beyond the aneurysm repair is recommended. So now I want to transition to talk about some of the key inflammatory diseases associated with aneurysm dissection and thoracic aortic disease. So the first is Takayasu. These are young patients, usually less than 40. They may present with symptoms of ischemia, as well as being detected to have aneurysms. So they may present with claudication or pain with walking in the lower extremities. They may have a diminished brachial pulse. They may have bruits over the subclavian arteries. You may detect a blood pressure difference between the arms. And usually there's some imaging evidence showing stenosis and potentially aneurysm. And here you can see the diagnostic criteria. Giant cell arteritis is also an inflammatory condition. In contrast to Takayasu, these are older patients, always above 50. It's associated with age. Similar to temporal arteritis, you may elicit a history of recent headaches, temporal artery pulsation or tenderness, jaw claudication. They will have a high SED rate, and biopsy generally will show necrotizing vasculitis. And you can see the criteria on the right. Now, Behçet's disease is generally a younger men with the oral or genital ulcerations. They can have pathergy, and they may present with uveitis and retinal vasculitis. To make the diagnosis, generally oral ulceration and 2 out of 3 of the other criteria. And then ankylosing spondylitis, usually it's people with pain onset in the back, less than 40 years old for more than 3 months. They get morning stiffness, subtle onset that can improve with exercise, and generally all of these criteria need to be present. Here are some images for a patient with Takayasu. This is a T-cell mediated idiopathic vasculitis. There's tissue destruction from inflammation, and that leads then to aneurysm as well as fibrosis, which can result in stenosis of the arteries. The incidence is about 2.6 per million. There's a 10-to-1 female to male predominance. There are 2 different types. There's the Japanese type, which involves the thoracic aorta and great vessels, and then Indian, which is the abdominal aorta and renal arteries. The acute phase is really associated with constitutional symptoms. There is a chronic phase where they have predominantly vascular symptoms, so they might have claudication, for example. CRP and SED rate are elevated in about 70%, but that goes down over time in the chronic phase. Here in the imaging, you can see there's evidence of stenosis, aneurysm. There's circumferential thickening of the aorta in this picture. Here you see tapering of the aorta. You can see several stenoses as well as this sort of focal tapering of the aorta, as you can see in this image here. So this sort of combination of multiple stenoses, narrowing and aneurysm of the aorta in sort of a young female should make you think about Takayasu. Giant cell arteritis is also a T-cell mediated idiopathic vasculitis. Again, in contrast to Takayasu, this is generally older patients. It's really very rare in anyone under 50, and the incidence increases with age, really peaks in people in their 80s. The incidence is about 20 out of 100,000, 3-to-2 female predominance. Again, constitutional symptoms, people may talk about malaise, fatigue. They may also talk about headache or scalp tenderness, jaw claudication, and of course visual change. And there's vascular involvement in about 25%, and this may be aneurysm of the aorta, dissection, or other large artery stenosis. For patients that have Takayasu or giant cell, the initial therapy should be corticosteroids at high doses, so prednisone 40 to 60 milligram or its equivalent to reduce the inflammatory state. The success of treatment for patients with either of these conditions should be periodically evaluated by exam, as well as tests such as ESR and CRP. And we really try to delay intervention or revascularization until the acute process is treated in quiescence. So you may be forced in some cases, but in general we try to defer any type of intervention until the acute inflammatory state has resolved. The initial evaluation of Takayasu or giant cell should include thoracic aorta and branch vessel CTA or MRA, so true axial imaging, to look at the possibility of aneurysm or occlusion in multiple vessels. So that really want complete thoracic imaging, and you may consider doing chest, abdomen, and pelvis to really get a full aortic survey. And then finally, it's reasonable to treat patients with Takayasu arteritis with receiving corticosteroids with an additional anti-inflammatory if they appear to be progressing in spite of the steroids, either by recurrence of constitutional symptoms or by inflammatory markers. All right, so we're going to wrap up now with the last section, which is the acute aortic syndrome. So we talked about aneurysm, we talked about atherosclerosis, we talked about vasculitis. Acute aortic syndromes describe a spectrum of disease where there's really acute disruption of the aortic integrity. There may be a classic tear in the intima, and that's what you see to the far left. This is sort of the classic dissection. All of these really result from disruption of the medial layer. You may get what's called a penetrating aortic ulcer, or PAU, or intramural hematoma. But all of these are considered along the spectrum of an acute aortic syndrome. These are associated with high morbidity and mortality, and rapid diagnosis really critical to optimizing care. Acute aortic syndromes occur at a rate of about 3 to 16 cases per 100,000 patient years. The outcomes are poor. About 40% die immediately. Mortality is about 1% per hour thereafter. And there's a high rate of perioperative and in-hospital complication, including mortality. Factors associated with acute aortic syndromes include hypertension. This is very common. There is a male predominance. You may have a history of trauma, even distant trauma, or intervention, so especially an endovascular intervention. There may be iatrogenic dissection. Think about vascular inflammation. We talked about Takayasu and giant cell. And then think about genetic connective tissue conditions, particularly for patients who develop this at a young age or who have concerning family histories. Now, as I mentioned earlier in the talk, although there is a male predominance, really what we see is that the incidence related to age is shifted in women versus men. So men tend to get these at younger ages, really with a takeoff of around 50 to 60 years old. Rates do increase in women too, but at later ages. And this is based on a 10-year study from the Oxford Vascular Study. Acute aortic syndromes and dissection are classified based on their location. There are two primary classification schemes. There's DeBakey, which you're seeing at the top, and DeBakey is type 1, one that involves or originates in the ascending aorta and goes at least to the arch and often beyond it. Type 2 is confined to the ascending aorta, and type 3 is confined to the descending aorta. The other classification system is Stanford, and so if there's any involvement of the ascending, it's type A, otherwise it's a type B. Now, although this appears very clear, there are entities that make management challenging. So for example, there are non-A, non-B dissections which are isolated to the arch. They're not in the ascending or the descending aorta. There are also more complex syndromes that involve the branches here. And so although we have a general approach, management of some of these subtypes actually becomes quite complex. But taking the Stanford classification of A and B, our approach to treatment is guided by robust epidemiologic and observational data. Here you see a classic paper from 2000 where patients are stratified by the type of dissection and how they were treated. Now, please recognize these are non-randomized data, and so these were selected patients, and therefore, whether or not they went to the OR depended on how sick they were, and could be a marker for sickness. But regardless, if you take the type A dissections, you can see that patients with a type A treated medically in yellow do very poorly, because generally these are patients who are too sick to operate. The standard of care is to operate. And those that make it to the OR have lower rates of mortality. For patients with type B dissection, those who require surgery, you see the opposite. These are sicker patients by nature of needing an operation, and they do poorly. And those type B patients that can be managed medically tend to do better. So type A dissections go to the OR. Type B, it depends on their stability, and we'll talk about that in a few moments. It's important to recognize that when we treat patients with dissection in the outpatient setting, we have to inform them about outcomes, because a lot of what they read in public resources is quite frightening. You know, what we all think about is what you see on the left here, is that if you take all comers, mortality rates, particularly for type A, are very high. About half of patients die before they reach the hospital. Another half die by 30 days. Type B has lower rates of mortality. But for patients who make it to the hospital, or diagnosed and treated appropriately, and are discharged successfully from the hospital, you can see the outcomes. Mortality is low, outcomes are good, and they're very similar for type A and B dissection. And so it's important to remind patients who have survived a dissection that their prognosis is not that we're seeing on the left, but rather the one on the right. All right, well, just to summarize, thoracic aortic disease requires astute attention for acute outcomes. In addition, it really requires recognition of risk factors in order to make the diagnosis, because largely this is an asymptomatic disease. When you make the diagnosis, all patients should have optimal medical therapy and risk factor modification. There are procedures for stable aneurysm that will reduce the risk of complications such as rupture and dissection, but the timing should be based on the patient, risk factors, clinical setting, the size and the rate of change, as well as patient's age and body surface area. In patients presenting acutely, consider acute aortic syndromes and image where appropriate. And I think one key message is really that imaging is key to this diagnosis, and that true axial imaging is highly sensitive and specific for characterizing these abnormalities, and should be obtained in appropriate patients. Here you can see a list of selected references. And now I will transition to our questions. So question number one, you have a 23-year-old man with Marfan syndrome who presents for evaluation. He's asymptomatic. You do a transthoracic echo, which shows a root of 4 centimeters. What monitoring is indicated? Do you do an echo every 6 months to determine the rate of enlargement? If the maximal aortic dimension is 4.5 centimeters or greater, or if the diameter shows significant growth from baseline, then you should do more frequent imaging. Do you do it every 3 months, or do you do it every 2 months? And that's B and C. So the answer is 6 months is what the guidelines recommend, and then if there are dynamic changes, you may do it more frequently. Question 2, a 62-year-old man of normal stature is discovered to have a thoracic aortic aneurysm that is 5.6 centimeters in diameter. He's asymptomatic and in good health. When should repair be considered for this patient? Is it A, when the rate of change exceeds 0.5 centimeters per year without considering the absolute dimension? Will it be at 6 centimeters, that's B, or will you consider it when it exceeds 5.5? And the answer is C. As we discussed several times, 5.5 centimeters is the threshold in general for patients who aren't expanding rapidly and don't have a connective tissue disorder. Now our final question is a 62-year-old non-diabetic woman of normal stature. She has a 5 centimeter thoracic aneurysm. She's asymptomatic. Serial imaging over 1 year shows no progression in size. She's a smoker. She smokes 1 pack per day. Which of the following should be included in her optimal management? Should you do stringent blood pressure reduction, Should you B, prescribe a statin, C, risk factor modification with a focus on smoking cessation? What is the right answer? Or is it D, all of the above? And the best answer here is all of the above. We want to treat the global cardiovascular risk.